Hello, everyone. I'm Asim Makhdom, the Orthopedic Surgeon at Orion General Hospital and Bradford Medical Center. So today we'll be talking about an interesting topic, which is hip and knee osteoarthritis, and what is the treatment ladder for both of these. The first slide here is my education and training. I did my residency at McGill, and I'm a fellowship-trained surgeon for joint replacement from Cornell and Thomas Jefferson University. The prevalence of osteoarthritis is one of the most common joint disorder in the United States. You can see that symptomatic men can be like 10% overall from the entire population, and 13% for women aged 60 and above. Some reports saying that actually women not only more likely to have osteoarthritis, but also they have the severe form of osteoarthritis. I'll be talking about the current advances in treatment of hip and knee arthritis. What is knee osteoarthritis? How would you classify that? And is there any preventive strategy? So when you see patients in your office as a primary care, what would you discuss with them? And what is the treatment ladder? And when should you send these patients for an orthopedic surgeon? I have some case examples for a few pictures from my own patients. All these were consented for permission for this presentation. Classification of osteoarthritis. So let's agree that osteoarthritis is OA. We're going to use that term. So there's primary OA and there's secondary OA. The primary, we'll talk in details about that. Here, this image showing that this is a normal knee. You could see the cartilage is covering the entire knee. This is the blue in blue color. If you look at this image over here, the cartilage started to fade away, and this is the arthritic process. You could see that osteophytes, which is extra bone formation, is also happening over here. This is radiographic images. This is a normal knee X-rays. You could see the black space between the thigh bone and the leg bone. The femur and tibia is well maintained. In this image, you could see that the space has narrowed. On the third space, that there is a severe bone-on-bone, what we call bone-on-bone arthritis. The entire space has completely faded away. Preventive strategies, control the weight. That's what you can tell patients in your office as a primary care physician, and eat healthy food as well, and avoid knee injuries. And if that happens, try to treat them quickly so you avoid early incidence of osteoarthritis. Of course, exercise also can help prevent knee osteoarthritis by optimizing your muscle condition. Treatment strategies, physical therapy, and optimizing your work and muscle around the joints, hip or knees, can honestly delay the incidence of this or help also treat the mild or moderate forms of osteoarthritis. Weight reduction is extremely important as well. Now, in mild or moderate cases, anti-inflammatory medications is very helpful. Tylenol as well. Some may ask about the supplements like glucosamine or chondroitin sulfate. There is no evidence actually these can regenerate the cartilage, and that has been studied extensively. One thing is just avoid giving your patients opioid medications, because that can put them at risk of future dependency. Injections in moderate forms, steroid injections can be really helpful. Viscous supplementations, the gel injections can be helpful. However, the randomized control trials showed no evidence to support that, but however, it does help some patients. You may have some patients asking you about the stem cells and PRP. Up to date, there is no evidence that these will actually regenerate the knee osteoarthritis. This is still experimental and under extensive research. And the American Hip and Knee Association had released a statement for that. And up to date, this is not recommended as a standard of care and has to be done only for research purposes. Unloading braces, again, it's a controversial, but in patients who are not candidate for surgery and they have really severe deformities, unloading braces can help. Now, surgical options, let's say the patient exhausted all the conservative options and nothing is really working. So now there are three options for knee osteoarthritis. One option is most of you guys are familiar with, which is the total knee arthroplasty. So in this image, you are replacing the entire knee, basically just the surface of the arthritis. So it's not a knee transplant, it's just removing the arthritic part and replacing that with knee components. In this image, this is a patient who had a partial knee, which is, we'll talk about the indications quickly. So let's say that you have a patient who had a localized arthritis, or the patient was young. You could do corrective osteotomy. So if the patient had a deformity, you could unload the joint to kind of minimize the pain and give him some time and hopefully also cure his disease. If not, then a partial knee replacement in some indications also can be helpful. This is an X-rays for one of my patients. If you see, he had a patellofemoral arthritis. So the arthritis was localized in one compartment, which is between the kneecap and the thigh bone. And successfully, I have replaced his partial knee only at that joint. So he didn't need to get the full joint replaced. And he's doing extremely well now at almost 2 years follow-up. I saw him actually a few weeks ago. This is a patient of mine as well. She had a deformity. If you look at here, there's a valgus deformity, so knock knee, we call it. She was young. She was 37 years old. And I did a corrective osteotomy, which is realigning the lower extremity. And you can see now the leg is straight 1 week after the surgery. Again, she's almost now 1 year and a half after the surgery, and she's doing extremely well, walking with no support, and she's very happy. This is the third category here. Patient comes with severe knee osteoarthritis and deformity. So he had, you see that the deformity was extensive here. And this is one of my patients. This is 1 week. He's walking with no cane or support, and his knee is straight now, and he's doing extremely well. Hip arthritis, pretty much similar problem here. If you look at this X-rays, you see that the joint here is still well maintained. This is a normal hip joint. If you see at this view, the cartilage has completely is completely absent, and what we call it bone-on-bone arthritis. The treatment strategies here are quite similar to the knee replacements. Here it's a physical therapy and weight reduction, so you could add weight reduction to this slide. And medications, again, anti-inflammatory medications for mild or moderate forms, Tylenol. The supplements, exactly what we talked about in the knee replacement. There is no evidence here to regenerate the cartilage, but some patients, they get some placebo effect from that. Again, I strongly recommend that you don't start your patients on opioids for mild or moderate arthritis. Injections, so it's controversial here, but some patients who had moderate or mild arthritis and exhausted the conservative options like physical therapy and other options, then a steroid can actually help them. The stem cells and PRPs, again, it's all experimental and under research and up to date. There's no single study showed that is actually can regenerate the cartilage. One of the technical aspects, most advanced technical aspect happened over the last maybe 10 to 15 years was the anterior hip approach, which is the muscle sparing hip approach. So you perform the hip replacement without cutting any muscle. And here is the interval between the sartorius and iliopsoas, and you could reach to the hip joint and replace it successfully. And this is one of my patients in the operative table. The patient will be in supine position, and the incision will be here in the front. And actually, in many cases, within 6 weeks, the patients can you. Yeah, thank you. Within 6 weeks, they have a faster recovery in terms of when you compare it to other posterior or lateral hip approach. And hopefully that was a short presentation, and hopefully that was helpful. And you guys can contact me anytime. And thank you so much for your time and for listening for this presentation.